Thank you all for joining us today. And since today is National Intern Day, I want to first take a moment to recognize our three amazing interns: Ames Government Relations intern Charles Schoenberger, MedEvac Foundation Digital Media intern Van Doe, and Foundation Sports Marketing intern Noah Stern. They've done amazing work for us this summer, and we're so grateful to have them and see their bright futures ahead of them. So this is our third in a series that goes through the rest of the year. We're doing the second and fourth Thursdays, generally of the month. We'll send out a link with a schedule to everybody so you can mark your calendars and share with your colleagues. Today, we're excited to be hearing from Dr. Michael Lauria on how to attain top EMS performance and stay in the zone. We all know that performing effectively during the resuscitation of a critically ill or injured patient requires more than simply remembering pieces of information and completing individual skills. These situations can be complex and require exceptional teamwork, effective communication, and a host of other skills. Professional athletes, business executives, and elite military special operations teams have developed comprehensive psychological skills and techniques that allow them to remain calm, think clearly, and stay focused in very challenging situations. Critical care transport professionals are no different. This lecture draws from the fields of psychology, cognitive science, and human factors to present new ideas on how to optimize performance in the stressful and dynamic with which we are all familiar. As CEO of the MedEvac Foundation International, and on behalf of our board, staff, and volunteers, especially our donors, who together make this possible, welcome. We've had about 165 people register for this webinar, and we know that hundreds more usually tune in after the fact. So if you're joining us after the fact, thank you for seeking this out and for tuning in. Just a quick housekeeping note, Dr. Lauria will do his presentation and then we'll do Q&A at the end. So I'll be back on at that point. But now I'm going to introduce Jared Hughes, who's the Foundation's Director of Development, to introduce our speaker. Jared.
Hey, thanks, Cameron. I'm super excited and honored to have Dr. Lauria with us today. The anticipation has been building now for several weeks, and if the dozens of unsolicited comments encouraging people to join us today from people sharing the invitation with their networks that I've been seeing on all the socials are any indication, this is going to be a really great talk and conversation. A little bit about Dr. Lauria. Mike is a former special ops medic in the military and critical care flight paramedic, now emergency medicine resident at the University of New Mexico. Dr. Lauria started working in emergency services in 2002 as a firefighter and EMT. He graduated from Dartmouth College in 2005 and enlisted in the Air Force, completed the rigorous pararescue training pipeline, and served at the 321st Special Tactics Squadron. He was deployed to Operation Iraqi Freedom as the primary medic assigned to a combat search and rescue team, Joint Special Operations Task Force. In October 2012, he returned to New Hampshire after accepting a position as a critical care flight paramedic for the Dartmouth-Hitchcock Advanced Response Team, also known as DART, and graduated with honors from the Dartmouth Geisel School of Medicine in 2018. He writes for Crit podcast, consults for various emergency services organizations, and speaks around the world on critical human factors, and he tweets under the handle Resus Padawan. You'll have to explain that to us a little bit. Obviously, a Star Wars reference. Little known hobbies: skiing, hiking, climbing, reading and writing about human performance under stress, which we're going to hear about today. Hanging out with his amazing wife, Jen, and his dog, Brody. He's a connoisseur of craft beer and local food. His favorite band is Journey, but circa 1977 to 1987. And something that you might not know is that he was on track to be an alpine ski racer in the Olympics, downhill and Super G, but he won $100 in an open competition and lost his amateur status and was disqualified. Ouch. So that's why you chose Dartmouth, obviously, for the skiing. I'm taking it.
Yeah,
welcome,
exactly.
Dr. Lauria. The floor is yours.
All right. All right, well, welcome, guys. I'm going to turn off my video here so you guys can focus on the presentation itself. So first of all, I'd like to really thank the MedEvac Foundation for for having me on today. It is a pleasure and an honor to support an organization that does so much for our brothers and sisters doing critical care transport and air medical transport around the country. It's really an amazing organization. And for those of you guys who are unfamiliar, I would encourage you to definitely check it out and see what they do and support their efforts moving forward. This talk is about how I think we can actually learn skills and develop techniques to really improve the way we perform in the critical care transport environment, and how we can stay in the zone during very stressful resuscitations and situations. First, I'd just like to say that I have no financial conflicts of interest. If I mention any products or any techniques or any things like that, it's because I think it's good science or it's a good program, and not because anybody's paying me anything. Of course, working as a resident for just about as little as the hospital will possibly pay me, if anybody has anything that they want me to talk about and get paid money for, I'm happy to entertain that. The other thing is that although I've dedicated a chunk of my career in the military and outside of the military to studying human factors and whatnot, I do not hold any advanced degrees in psychology or cognitive science, at least at this point. So don't take this as actual psychiatric or psychological recommendations. This is my personal beliefs, both seeing it from an operational standpoint and researching it as an academic. So. As had been mentioned previously, I kind of started out my career before college and then really sort of got it kicked off when I was at PJ in the Air Force. My job was to provide combat search and rescue capability to various special operations teams around the world, as well as direct medical support to some of those teams on the ground, which was amazing and really kicked off my interest in performance under very stressful conditions. When I left, I had the opportunity, I loved flying and I loved the medical piece of things. So when I got out of the military, I went back home to New Hampshire and got a job working with the amazing Dartmouth-Hitchcock Advanced Response Team, the DART team at Dartmouth-Hitchcock Medical Center, where I really learned the craft of civilian critical care transport and was mentored by some amazing people, both in the program itself and in the hospital, who eventually encouraged me to go ahead and pursue my academic masochism and just go back to medical school. So I graduated from Geisel, the School of Medicine at Dartmouth, in 2018. And the University of New Mexico down here was kind enough to accept me into their emergency medicine program, which has been fantastic. And I just cannot get enough of flying. So I continue to fly today for the lifeguard program as a resident physician and part of our growing flight physician program. So I'm very excited about that. And we have an awesome team out here too. This talk is really about understanding how we're human, about how we think, about how we act, about how we communicate, about how we interact with the environment around us when we're really stressed out or in some of these very challenging situations. And I think understanding that is really the key, because once you understand how your brain works under these situations, then now we can adapt tools and change training paradigms to better meet those demands and those requirements. So this talk is really about learning psychological skills to perform under acute stress. We're going to start out by talking a little bit about stress and performance in general, and then go into performance enhancing psychological skills and ways I think we can actually learn to develop some of these things. But it all kind of started out for me when I was in the military. This slide highlights, by the way, why my special operations career terminated at the rank of staff sergeant, is because I just couldn't grow a strong Viking beard. My facial hair was actually pretty weak, so I had to get out as a staff sergeant. But I got to work with some of the most amazing dudes on the planet. It was absolutely fantastic. They were an amazing group of guys. And what really impressed me about these guys was the fact that they were able to, no matter how stressful the situation was, no matter how dangerous things were, no matter how things were going sideways, they were always able to kind of see through the fog of war. They were able to find this crystal clear path through the chaos and stay calm and figure out how to get out of whatever situation we were in. And that, I thought was pretty amazing and pretty interesting. The thing was that we didn't have like high level academic conversations about cognitive science or anything like that. What I saw was that people had developed and learned techniques over time throughout the course of their experience in the military to combat stress and perform better. For example, one of our breachers, whose nickname was Bull, was a huge, 260 something pound, muscled out dude who was just amazing at two things. One, lifting very, very heavy things over his head, and two, blowing things up. And it was very interesting. So I distinctly remember a mission we were on where Bull was talking to me about how we prepared for the mission, because we didn't have a long time to prepare for this mission. It was relatively complex. And basically what he would say was, in order to gain access to the house, when we were going to where the team was going to assault the house, he would replay in his head. He would look at pictures of the target building, and he would replay in his head. He would imagine like how many steps it would take to get from the front gate to the front door, how many steps back it was from the front door to where the team was stacking up. He would imagine what the charge felt like as he pulled it out of his pocket and hooked it up on the door, and where he was going to place it on the door, and all these things. He would basically run through it in his head. And he said, basically, it's like playing this videotape over and over again in my head. So when it comes time to actually perform, when it comes time to do it, when it really counts, he's like, it's no big deal. I've done it like 1,000 times over in my head. I'm just replaying the tape that I've already developed for myself. And that was pretty neat. I also had friends who were precision marksmen. They were snipers, and they would discuss things like the importance of controlling your respiratory cycle when you were very stressed out, because your respiratory cycle actually controlled or was correlated with the perfusion to the retina, and how your eye actually focused on the reticle of the sniper rifle, and how even small changes in perfusion and respiratory rate could translate to many inches, 6, 12 inches off target at 500, 600, 1,000 yards, which was basically the difference between making the shot or missing the shot. I still had other friends who, despite the fact that they were in the special operations community, they weren't always thrilled about certain activities. So one team member in particular, who was actually a fantastic parachutist, hated parachuting. He hated it. He ultimately admitted to us that he was scared all the time to do it. However, you never know it. You never know it. He was an amazing parachutist and really, really good. And he said basically he had this little mantra in his head that he would talk through as we moved to the edge of the ramp and got prepared to jump. And that would keep him calm, and that would keep him focused. And it certainly worked, because it was certainly not evident to us as he was just an amazing operator. So even more interesting in all this was I happened to be going back and doing a clinical rotation at the Shock Trauma Center in Baltimore, at the University of Maryland Medical Center. And it just happened we were in the trauma resuscitation unit one day, and I'll never forget, we got this call, and Trooper One of the aircraft was landing on the roof with a gentleman that had been shot several times in the chest. And this gentleman lost pulses as they were unloading him on the roof and coming downstairs. So traumatic arrest in the setting of penetrating trauma to the chest. And I'll never forget what the trauma surgeon said. He looked over at one of the fellows and he said, okay, we have like 3 minutes to get down here. What do you want to do right now? And the fellow went on about, like the ABCs and all these other things that he was going to do in his big plan. And the trauma surgeon stopped him and said, basically, there's one thing, we have one shot at saving this guy's life right now, and that's our trauma arrest algorithm, penetrating traumatic arrest algorithm. And he talked about, well, the key feature of this was basically gaining access to the chest and the pericardium. And he walked through with this fellow performing a clamshell thoracotomy. And he explained to the fellow how he would imagine and how he likes to think through in his head before the patient hits the trauma bay, where the different equipment is going to be, what it's going to feel like to pick up the scalpel in his hand, where he's going to make an incision, how he's going to get through the sternum, all of these things. And what I realized was this very experienced trauma surgeon was doing the exact same thing as this very experienced Army special operations dude, my friend Bull. And that was fascinating to me. I'm like, here's two super smart, amazing, super high performing guys who have never met one another, and they've adapted the same technique to help them perform under stress. So I thought that was just fascinating. It blew my mind. But I thought this was all psychobabble BS. I thought this was like Jedi mind tricks. There's no way there could be any science behind it or actually any proof that these techniques or concepts actually work. And I was totally wrong. There's a ton of literature going on these topics, on these performance psychology topics, on these different skills and techniques going back to the 60s and the 70s. There's probably more evidence to support some of these things than there is good evidence to support a lot of the things that we tend to do in the pre-hospital environment. And I thought that was just unbelievable. And so it seems that there's evidence for this that supports it for high performance in the military special operations setting. Extreme athletes and extreme sports have adopted a lot of these techniques. And when you talk to some of these guys, they use some of these psychological skills on a daily basis. NASA actually has a psychological skills training program for their astronauts. As you can imagine, hanging off the side of the space station or the space shuttle is a little stressful. And I can tell you from personal experience and the experience of many of my colleagues that some of these things help when you're transporting a critically ill patient that's crumping in the back of your aircraft at 2 a.m. So why does this matter? Why should we even care about developing a lot of these psychological skills or these techniques? And the answer is stress. The understanding or our concept of how stress affects our behavior and our cognition is actually very well documented and important to understand. And how we think it works is through this process called an appraisal mechanism. So in an appraisal mechanism, basically you're going around, and as you are approached or as different scenarios are presented to you, whether that's a critically injured kid on the side of the highway or a very sick septic patient at an outside hospital, your brain basically does this psychological math. It basically assesses the situation and asks a relatively simple question. Do I have what it takes to be successful in this situation? Do my resources actually, are they able to meet the demands of the situation? If they are not, if you're like, oh my gosh, I've never intubated a 5-year-old before. Oh my gosh, I've never had an OB patient, a very pregnant patient at 35 weeks that's been hit by a car and now is unresponsive. Well, my gosh, like what am I going to do? Then you go into what we call this threat mode. And in the threat mode, it's an important psychological turn where your behavior actually changes. You become increasingly stressed instead of actively being very goal-oriented and trying to pursue your clinical guidelines. You become very introspective and are like, oh my gosh, what happens if I screw this up? What happens if this patient dies? I just got to keep her alive. Just keep her alive until we get to the hospital. And we see maladaptive behaviors and responses as well. Now contrast that against the challenge mindset. So in a challenge mindset, what we see is people actually rising to the occasion. This is like the trauma patient that you've seen like 200 times. You're like, okay, this guy's got to get blood, TXA. We're going to do this. We got to resuscitate him and at least get his pressure up a little bit before we give him induction medications and tube him. I got to do X, Y, and Z. You have a clear plan in your head. You know that you can make a difference in this patient's outcome. You know and are comfortable with the skills that have to be done. And in this scenario, we see what we call as, or colloquially refer to as, a playing to win mentality. You are goal-oriented, focused, you know you can make a difference, you're trying to optimize the patient and do the very best, and you are comfortable and in your performance zone, if you will. Now, what's kind of interesting is we used to think that these were just psychological skill states, but our colleagues overseas, in particular in the United Kingdom, have done studies that actually show there are changes in cardiovascular parameters when you're in these different psychological skills, psychological mindsets. So for example, in the challenge mindset, so you're psyched, you're ready to go, you know you can do this, you are motivated, you can help this patient, you're comfortable with the skills. What we see is people's cardiac output goes up, and their tissue peripheral resistance, or their systemic vascular resistance, actually goes down. The perfusion to a lot of their tissues increases. They seem to be like well-seasoned athletes, actually increasing their cardiac output and decreasing their resistance. Now compare that to people who are in a threat mindset. What we actually see is their cardiac output go down, largely as a function of the fact that they're almost like that patient who's pale and diaphoretic and looks like they're having a heart attack. Their systemic vascular resistance, their tissue peripheral resistance goes up, largely as a result, we believe, of increased sympathetic tone and that adrenaline super dump that you get under these circumstances. So this is definitely not the hemodynamic picture that we would want to perform well, essentially in any environment. Now, I think it's important to mention that there are definitely some distinct cognitive and perceptual problems that occur when you're in that threat mindset. And that threat mindset, that stressed out mindset, normally we explain your working memory. That is your as your cognitive bandwidth. It's kind of like the bandwidth of the Wi-Fi at your hangar or base, right? It's essentially finite. And if everybody in the hangar gets on and starts downloading huge videos or streaming movies, then your ability to download that information goes down significantly, right? The video stops up, you get the spinning wheel of death, et cetera, because you've overloaded the bandwidth of that Wi-Fi. Now, the same thing is kind of true with your working memory. It is essentially finite at any point in time, and it very quickly gets clogged up with all sorts of things, like those negative self-thoughts, like, oh my gosh, like what happens if I screw this up? What happens if I can't get the tube in? What happens if I miss this IV? All of those things actually take up that cognitive bandwidth. And what we do know is that cognitive bandwidth seems to get jammed up when you're stressed out. So we believe that functionally it seems like it shrinks, which is definitely not good. We also see some other interesting behaviors. So people get tunnel vision. I'm sure many of you have seen this before. People get hyper-focused on things that are perhaps not that important. People can get auditory exclusion. So there are a number of documented events, especially in the aviation industry, where the black box clearly records, clearly has evidence that the co-pilot or pilot will say something to the other individual in the cockpit and saying something like, hey, we're very low, or hey, we need to pull up, or hey, we need to do this or do that. And in retrospect, that either A, doesn't seem to happen, or B, God willing, the people involved in the accident actually survive. On questioning those people, they're saying, I never remember hearing that. I never remember hearing the alarm. I never remember hearing the warning. I never remember hearing my co-pilot telling me X, Y, and Z, because our sensorium is changed when we're very stressed out. And auditory exclusion is a known side effect of that. Also, our ability to triage information seems to be impaired as well. Normally, if I gave you a test and I gave you, a triage question and said there's someone who's got difficulty breathing and they're breathing like 30 times a minute and their oxygen saturation is 72%, and there's someone with a mangled left lower extremity, but otherwise, aside from being slightly tachycardic, their blood pressure's fine, they're breathing okay, their oxygen is all right, they're mentating fine. You would probably be very easily able to tell me, oh, well, duh, the person with the B problem, the person with the breathing problem needs to be taken care of first because of ABC, et cetera, assuming that the mangled extremity wasn't bleeding all over the place and actively hemorrhaging. You'd probably say, we need to take care of the breathing problem first, which is correct. However, when you're super stressed out, that ability to triage information essentially disappears, which is why we always have to tell people, don't get focused on the eye-grabbing, very vivid injury. Go back and assess A, B, and C carefully. Now, paradoxically, you also seem to get distracted, right? I said you get very tunnel vision, but you can also, ironically, it's very easy for you to change that tunnel vision or get switched from getting focused on one thing to something else, which is not terribly helpful. And finally, we see what we call cognitive perseveration. This is what we call the broken record effect. When people are stressed out and they don't know how to solve a problem, they get the laryngoscope in the mouth, they're going to intubate someone, they cannot, for the life of them, find the epiglottis, the glottic opening, or the vocal cords. And you ask them, what do you see? What do you see? They're like, and all you see is them kind of wiggling the laryngoscope around the mouth. They're not demonstrating goal-oriented behavior. They're not performing discrete skills that we know or have good evidence will increase our percentage glottic opening or increase our chances of actually successfully intubating the patient. They're just kind of moving the laryngoscope around, rocking it back and forth, praying desperately in their head that they'll be able to see something. That repetitive motion that we call the broken record effect is because your brain doesn't know what to do. And when it's stressed out, very rarely, occasionally, we see episodes or examples of people having these flashes of insight and being able to quickly problem solve things. But in reality, that is the minority, not the majority. And what we see is that people tend to just do these repetitive behaviors over and over again, quite unsuccessfully, I might add. And in general, although my human factors colleagues would balk at this diagram as a gross oversimplification of performance and psychological pressure or stress, it is sufficient for purposes of this talk to understand the simple concept that there is an optimal level of arousal. So you want to get some excited. It's like when the tone goes off in the firehouse, or when you get paged out, or the radio goes off and dispatches you to a scene flight, and you get that initial rush of adrenaline and excitement to go do your job. That gets you ready, it gets you focused, it brings you up to this peak, this optimal performance peak. However, too much adrenaline, too much arousal, too much stimulation, too much stress puts us on the right side of this diagram where we see strong anxiety and impaired performance. And eventually, if the stress is high enough, we see complete meltdowns. This is when people like your new orientee or something like that completely freeze up. They basically don't know what to do. You need to direct them very carefully because they're so stressed out and overwhelmed that they're like a deer in the headlights. And that is not helpful for everybody. The important thing that I think we should take away from this, though, is that this curve is malleable and not static. In other words, it can change. We have some pretty good evidence that we can actually extend this level of optimal performance and keep performing very well at high levels of stress. And the question is, how can we do that? Well, there's essentially several ways that we can do that. The first is basically time and exposure, right? We know that people who have been doing this job have slowly adapted over time. After many calls, they've been able to do better. They're used to the stress of the situation, which is a very common thing. And that we do have some interesting evidence for as well. We've evolved with this ability to adapt to our environment. So our brains over time actually adapt to that level of stress and adapt to seeing super sick, critically injured patients. And when we experiment with this, when we actually do experiments that look at brain activity, so when we actually do EEGs on people that are presented with stressful or very challenging situations, what we see is the electrical activity is all over the place. It's like very turbulent river rapids. And it almost, you could almost say it looks like they're having a seizure because there is very disorganized electrical activity around their brain. You can imagine the different parts of their brain aren't talking very well to one another, and there's a lot of introspective self-talk, negative self-talk, and thoughts about what might happen if things don't go well. Now compare that to people who have done the scenario or been in these stressful environments multiple times, and what we see is that EEG is nice and smooth. There's much more fluent electrical activity around the brain, in particular between the motor cortices and executive cortices, between the motor cortices and areas of the brain that control things like attention. So what we think is going on, and we don't have definitive evidence on this yet, but our hypothesis is that in these situations where you're calm, cool, and collected, you're able to focus on the important stuff more readily, and your brain is better coordinating activity. What we also see is we can actually look at functional MRI and look at different areas of the brain that get blood flow and light up under certain situations. And what we can see is there's less blood flow and there's less activity in the amygdala, which is sort of the master control for the stress response, if you want to think about it that way. And what we see is there's less activity in there once people have been accustomed to or run through a scenario multiple times, or at least subjectively say, no, I was fine with this. I was calm, cool, and collected. I'd seen this a million times, compared to people who were like, oh my gosh, I didn't know what to do. I was kind of stressed. What's perhaps even more interesting is that what we've seen is some people actually seem to have developed the ability to express certain neuropeptides that seem to mitigate or damp down the stress response. There's ongoing research in this area to really determine how and what increases expression of these. Is it something that people are born with? Is it something that they seem to develop over time? And if so, how can we use this as a metric to see how we're training people effectively, especially in the military setting? Now, number two. So that's great if over the course of 7 to 10 years, people just sort of adapt to the situation. Awesome, right? However, it doesn't really help you or me tomorrow to say, well, in 10 years, you'll figure it out. That's why I think that this is perhaps very important, is you can develop active cognitive and behavioral techniques, incorporate them into your training, and over the course of weeks to months, be able to more effectively perform in this environment. And I always think of this story because I was actually at the military combatant dive program. I think most people think of the special operations selection programs as being very challenging. The combat dive school in the military is probably one of the most challenging because it's actually easier than you would think to go through abuse and be awake for long periods of time and go without food. However, going without oxygen, on the other hand, is much more challenging and much more stressful. So even the biggest, most muscled out, very intimidating looking tough guy, you take away their oxygen for, like 30 seconds or a minute, and you'd be surprised at how they freak out. So this is one of the determining factors. And one of the ultimate culminating exercises is something that's called one-man competency. They basically take you down to the bottom of this 15-foot pool. They put a blacked out mask on you, and the instructors basically go to pulling things off you, removing your oxygen source, and your only goal over the course of about 20 minutes is to survive and keep on breathing from your regulator. And I totally failed. I ended up passing out on the bottom of the pool, and I had to be pulled off the bottom of the pool. And when I came to, when I regained consciousness, I was very quickly told that I had failed and I'd be going home. So that felt awful, and felt very dejected, and was like, oh man, I worked so hard for so long, and here I am, I just failed this course, and now I got to go back home with my tail between my legs. And one of the instructors, as I was sheepishly dragging all my equipment and shamefully going to pack up and go home, told me was, in fact, hey, it's really about engaging your brain, engaging your mind to control your heart rate, to control your level of stress, because what you're doing is not technically complicated. You just have to be able to stay calm and keep your heart rate down when you lose your oxygen source and when you're not able to breathe. And that really stuck with me. And we went home and we practiced just basically, trying to slow your respiratory rate down, trying to slow your heart rate down, trying to stay calm, even though you're underwater and can't see anything. And it worked. Eventually I went back and passed, but it taught me that there are distinct skills that we can actually learn in a relatively short period of time to improve our stress management skills. And it shouldn't be too surprising that it can affect our performance, because this is what we call the cognitive triangle. And basically what it comes down to is what we think, what we feel, and how we behave or how we perform are all intimately intertwined in this giant neurological spaghetti that we call a brain. And I would hasten to add that this should also be not surprising to us, because this actually is the cornerstone upon which cognitive behavioral therapy, which, by the way, is the #1 evidence-based technique for helping with psychiatric disorders and problems on the anxiety disorder spectrum, for improving those things, right? Improving or mitigating anxiety. So what this basically comes down to is that we can leverage what we think to affect how we feel and how we perform. And this is absolutely true. And so what we developed was something we call PEPS, which stands for Performance Enhancing Psychological Skills. And we looked at the low-hanging fruit. What were things that I thought could work in the emergency department, in the ICU, in the back of an aircraft, on the side of the highway, skills that emergency providers could easily draw on and fit well into our skill set. And what we came down to was breathe, talk, see, and focus. So these are 4 distinct skills, and the way we remember the mnemonic is beat the stress fool. So the first skill is breathe. So if you think about it, it's really interesting, right? Because breathing is really the only autonomic skill that we have conscious control over, right? We can't just think our blood pressure lower. We can't think our heart rate lower, but we can consciously hold our breath or change our respiratory cycle. And that's what this is about, because we know that a controlled respiratory phase, when we actually study it, has been shown to blunt the effects of increased sympathetic tone and activation of the hypothalamic pituitary adrenal axis. And again, this should probably not be that surprising, because Eastern cultures, different martial arts practices like yoga and various other activities have espoused these techniques for thousands of years before we were even able to study them. And they do seem to work. At least how it's studied in the literature is something called tactical breathing or box breathing or performance enhancing breathing. And basically what you're doing is you're taking a deep breath in for about 3 or 4 seconds. You're holding it in for 3 or 4 seconds. You're exhaling for 3 or 4 seconds and holding it out for 3 or 4 seconds. And this technique is repeated several times depending upon which study you read, and that can actually lower your heart rate, and subjectively it seems to lower people's stress and anxiety. Talk is the second skill. Positive self-talk. It reminds me of this beautiful Cherokee legend about a grandfather who's explaining to his grandson how people make the right decisions, or how people deal with situations where there is tension between 2 choices. And he basically tells his grandson, you know, it's like there's 2 wolves inside everyone fighting. When you're trying to make a decision about what to do, those wolves are basically fighting one another. And one wolf is representing all of the good things in life: joy and happiness, justice, fidelity. The other one represents all of the not so good things like hatred, jealousy, fear, anxiety. And he's like, these 2 wolves are always fighting one another when we're trying to make these decisions. And the grandson, the legend goes on, the grandson very in a very precocious manner asks his grandfather, hey, so how do we know which wolf wins? And the grandfather tells him, the wolf that you feed is the one that will win. In other words, the dialogue that you have with yourself, the information that you feed yourself, directly impacts the decisions you make and how you think and feel. And when we study this in the world of cognitive science, we call this cognitive reframing. Remember that whole appraisal mechanism is based on just that, an appraisal. How your brain perceives the situation in front of you. And if you change that perception with information that you feed your own brain, you can impact that. You can change the way you see a situation. For example, you land on scene on the side of a large interstate highway, and there's a minivan that's been destroyed by some semi-tractor trailer, and there's a super sick, critically injured 5-year-old kid with facial trauma and chest trauma, and you're like, oh my gosh, oh Lord, please help me here, because I haven't had a kid like this before. This kid is super sick. The parents are there screaming and crying, and it's all on me. All eyes are on me right now. Oh my gosh, I hope I don't screw this up. What happens if something bad happens? What happens if the kid arrests in the back of the ambulance or something awful? And you change that frame of reference. And you're like, okay, this kid is super sick, but you know what? I'm here now. I've intubated kids before, granted not that much, but I've intubated plenty of adults before. The same principles hold true. I have to manage his airway. I have to take care of his breathing and oxygenation. I have to stop any external hemorrhage, and I have to resuscitate this kid effectively. The principles still apply, and I can do those. This kid needs me right now. His parents need me right now, and this is my chance to make a difference. That is cognitive reframing. That is having a dialogue with yourself that gets you focused and motivated to do your job, as opposed to backing off and becoming scared and anxious in that situation. The nice thing for us is this talk can be motivational, like the example that I just gave you, or it can be instructional. It can be instructional for discrete tasks, which I would argue is actually very important. And the way we structure that language is short, specific, and positive. So for example, here you are, you're going to intubate this kid, and you're trying to tell yourself, okay, so I'm going to get my laryngoscope out, I'm going to go down the tongue, I'm going to see the epiglottis, I'm going to get into the vallecula, and then I'm going to be able to lift the epiglottis up and see what I got to see. Short, specific, positive. You definitely, and positive is very important here, definitely don't want to be telling yourself, don't screw this up, don't screw this up, don't stick the endotracheal tube in the esophagus. You want to be positive and focused on successfully achieving whatever specific skill that you're trying to do. Seeing, or visual practice, or mental rehearsal, or mental practice is also very important. As it turns out, if you're actually thinking about an activity in detail versus actually performing that activity, whether it's swinging a golf club or playing the piano or something like that, your brain actually seems to, when we perform functional MRI on these people, the same parts of the brain light up. In other words, we think that you're actually using the same neurological architecture to imagine or think about the scenario instead of actually, as opposed to actually doing the discrete skill. And that's kind of interesting, because just like my friend Bull, who I talked about at the opening of this talk, when you're actually imagining that scenario, you're giving yourself essentially a practice run in your mind. And by keeping that imagery very vivid and specific, you are again activating that same neurological architecture you'd be using to actually perform the procedure. And people have discussed exactly what you should be thinking about, or how you should be structuring this mental imagery or mental practice. And it should not only be the vivid physical nature of what you're doing. In other words, imagining what the laryngoscope or the video laryngoscope feels like in your hand, imagining what it's going to be like to scissor open this patient's mouth, imagining what it's going to look like and feel like as you pass the bougie into the trachea. Also imagining the environment around you or specific to you. For example, you imagine yourself in the back of an ambulance, or if you're in an outside hospital, imagine yourself in that outside hospital. The timing and sequence of the skills, and ensuring that it's in the perspective that you'll be using. In other words, you don't want to imagine yourself in the corner of a room like you're doing it in the third person. You want to be seeing the airway from the first person perspective if you were doing a visualization for airway management. Now this, interesting enough, has been studied, at least in the emergency medical environment. Our friends in Toronto published a very interesting paper looking at trauma teams. What they did was they took anesthesia, emergency medicine, and surgery residents. They controlled for level of experience, and they divided them into a bunch of different groups. And they randomized the groups to, before a simulated trauma patient scenario, actually do one of two things. One, the first set of groups actually got to do skills practice. They got a refresher, basically in advanced trauma life support, and then went in and did the scenarios. The other group was told, hey, sit there and you're going to be the anesthesiologist at the head. You're going to be the surgery resident at the patient's right side. I want you to imagine doing the different skills that you may have to do. Imagine drawing up the drugs and doing the intubation if you're the anesthesia resident. Imagine putting a chest tube on the right side of the chest if you're the surgery resident. Walk through all the steps in your head and mentally prepare yourself. And interestingly enough, to a blinded panel of judges, the teams that did the quiet mental practice performed significantly better on a validated team performance score than the people who actually just did the skills performance, which was interesting. Granted, single center needs to be reproduced both inside and outside of the hospital in a larger randomized control setting, but does actually show a signal that it does help. And lastly is focus. So focus is about using a trigger word or short phrase to transition you from a preparatory phase of like getting all your equipment together to do something and actually doing it. Because we know that with a lot of critical procedures, the classic one being cricothyrotomy, one of the most important things, or one of the biggest bottlenecks, is just the decision to do it, right? We hear that over and over and over again. So focus is about using a word that transitions you, because what your brain attends to, or focusing on information, is very important. And in the human factors world, what we tell people is what your brain focuses on is kind of like a flashlight. It's either bright and tight and white, or it is dimmer and broader. So if it's dimmer and broader, that's like a scene commander or someone who has overall view of the situation. That's helpful. But when you're performing discrete skills, whether it's analyzing a blood gas, or looking at a patient chart, or putting in a chest tube or intubating someone, a discrete skill, your brain's focus needs to be 100% on that skill. If it's not, if you're distracted at all, we know that that directly correlates with increases in errors and increases in failed attempts at whatever particular skill we're looking at. So you want 100% of your focus to be on the skill. And that's why the trigger word that I actually use is focus. So, you know, I get in the back of the ambulance, you realize it's a very sick trauma patient, you're going to manage their airway, get all my equipment together. As I'm getting my equipment together, I'm going through my visualization and mental practice of how this thing is going to go down. I'm giving myself my positive self-talk. And then as I am ready to go, and right before or right after we run the checklist and the drugs get pushed, I take another couple deep breaths and I actually say to myself, okay, focus. And that gets me ready to actually perform the discrete tasks. Now, so we talked about number one, just sort of gaining experience over time. We talked about individual skills that anyone on this webinar or any of your colleagues can actually pick up over the course of weeks or months and practice on their own. But really, perhaps one of the best ways to do this is develop a comprehensive training program that incorporates all this stuff. And I can't help but think about our special operations training and selection program, where we went through these very heinous exercises in the pool, even before dive school, one of which was called ditch and dawn, where we had to tread water for, some ridiculous period of time, dive down to the bottom of the pool, take off our weight belt, take off our fins, set them up in a particular way, and then actually tread water again, go back up to the surface, dive back down, put everything on, go back up and tread water again. So it was this repetitive thing, and it was exhausting. I mean, it smoked. It's like you're sprinting for several minutes and then having to hold your breath for several minutes while you perform a focused activity. And we literally thought we were going to die because you just can't breathe. You're almost on the verge of passing out, and people are yelling and screaming at you. And I never will forget one of the days one of the instructors came up to us, and he was like, I know you think that we're trying to kill you right now. And we were all thinking, yep, we're pretty sure you're trying to kill us. But he's like, I want you to experience what this is like now, in a safe environment, in this clear pool, with dozens of instructors around who, God forbid anything happens to you, they can dive down and save you, or they can help you out. I want you to be able to practice, know what it feels like to experience this stress, both physically and psychologically, in a safe environment where if you screw up, we can help you, or if you screw up, we can go back and you can change your approach to things, and you can understand, you can feel those feelings of stress and anxiety, come up with ways to mitigate them. That was critical because it changed what we were doing from, oh my God, or how we were thinking about these exercises from, oh my gosh, they're trying to kill us, this is miserable, to this is an opportunity to practice these skills and push ourselves when we have a safety net, as opposed to doing it in the North Atlantic in the middle of the night, where if something goes wrong, you will sink to the bottom of the ocean and die. This is the essence of understanding what we call stress inoculation training, where we're trying to have specific educational goals of gaining knowledge and familiarity with the environment, develop and practice specific tasks and skills, and build confidence. Probably the key one here, right? We often see people throwing people into very stressful situations with smoke and all these other crazy things, and yelling and screaming at them and saying, I put them through stressful situations and scenarios. We're doing stress inoculation training. But what happens is when you don't put in the precursors and the building blocks and develop people enough and just throw them into these scenarios, what you end up doing is crushing their confidence, and people get dejected and upset and frustrated. And what we really need to do is build their confidence. And confidence going into these scenarios is or does correlate very well with performance. So phase one of this training is just information provision. That's what I've done with you here today. Explain about the normal stress response. You adjust their expectations and make them understand that, no, they're not superheroes. They're human. They can expect that they will get stressed out. They'll forget information because their brain is overloaded. They're going to make mistakes. They're going to overlook some things. And that's okay in the short term because that is a normal response to stress. And believe it or not, when you change people's expectations to better match reality, what it actually looks like, that it's normal to get stressed out. It's normal to have auditory exclusion. It is normal to forget very simple pieces of information like drug doses. Then actually people perform better. Just knowing that information, feeling more comfortable and understanding that they're not a screw up or stupid or incapable of doing their job. Phase 2 is skills acquisition. And this is the important practice. This forms the foundation of all things to come and is also the most overlooked part of the practice, because it is not just doing something over and over again that counts. It is how you do that training over and over again that counts. And in this case, what we're trying to do is develop well-defined goals. For example, I want you guys from the time of identifying can't intubate, can't oxygenate, can't ventilate, to effective placement of a cricothyrotomy in the trachea, 30 seconds or less. That is a defined goal. Focused, repetitive practice. So you're focusing on this one particular skill. You're doing it multiple times until people get it right and they're able to execute it smoothly. You're increasing the difficulty. So maybe making, first putting a skin over the mannequin that's very thin and easy to get to, and then putting some fat and other tissue in the way, making it harder in the simulated environment, with reliable quantitative feedback. So perhaps in this example of surgical airway training, you're actually timing people and video recording people, showing them what they're doing, showing them how long it takes, and then giving them effective evaluation. In other words, qualitative feedback, like, hey, I noticed that the way you set up the kit was like this. Maybe you could move faster and shave a couple seconds off if you did that. This is important. And I would hasten to add, before moving on to phase 3, that phase 2 is where you incorporate the psychological skills with the technical skills. So you teach people, all right, as soon as you figure out that you're in a can't intubate, can't oxygenate, can't ventilate scenario, announce the scenario. This is a failed airway. You can't intubate, oxygenate, or ventilate the patient. You're moving to cricothyrotomy. As soon as you say that, take a couple of deep breaths as you're pulling the cric out. Go through the discrete steps in your head quickly, and then go to town. Phase 3, application and practice. I think of this as tempering your ability to deal with the stress. Now that you've explained the situation, you've developed the skills, now it's time to practice them. And basically what we're doing is we're turning up the volume. We're gradually adding on various stressors. So intrinsic stressors. You're making the clinical scenario more difficult and more complicated. There's more pieces to the puzzle they have to solve. Extrinsic, you're adding on a worried mom or dad that's bothering them. You're adding on EMS personnel that accidentally drop things on the floor to make things more difficult for them. You're adding on the batteries in the laryngoscope stop working. All those other little things that are extrinsic to the clinical situation. And finally, the socio-evaluative stressors. So actually, this is key for a lot of EMS personnel. We don't like people standing over us with a clipboard. So you're adding on a socio-evaluative piece that also adds on a little bit of stress as well. And this is the job of a seasoned educator to decide for your personnel, for your people who you're working with, how are you going to adjust these different things, and at what rate are you going to increase these things? Now, what I'm suggesting has discrete limitations now that we're coming to the end of this talk. It has to be individualized. What stresses me out doesn't stress other people out, and vice versa. You still have to train the technical skills. Please, please, please don't mistake what I'm saying for that we can just sit around and hold hands and sing Kumbaya and imagine ourselves getting better and suddenly we'll be able to resuscitate people better. Absolutely not. We still need to do our competencies, still do our skills training, still do our clinical rotations, and incorporate this stuff. Now, you also have to incorporate it into your practice, your flow, and how your system works, how your program works, your equipment, all those things. You have to take these skills and blend them, superimpose them on how your normal clinical operations work if you want it to work effectively. It's silly to imagine us saying, okay, time out in the back of the ambulance. I just have to do my little meditation here. You guys have to give me a couple minutes. I sit down and do this. Not going to work, right? You have to incorporate it into your normal operational flow. And finally, this particular set of things has not been investigated in the air medical environment, nor to my knowledge, these 4 specific skills have been investigated in together as a group in the environment of the ED or the ICU, but we're working on it. COVID has sort of set us back a little bit, both at my institution and at several other institutions. We are working toward randomized controlled trials and other investigations looking at these interventions to see if they actually improve performance or quantitative metrics. So remember BTSF, breathe, talk, see, focus. I think that if we begin to incorporate these things, we can actually improve our performance. We can decrease our own levels of stress, which I think both acutely and chronically is important. And most of all, I think that we owe it to ourselves, we owe it to our patients, and we owe it to our colleagues to perform at our very best every single time and be able to stay in that high performance zone. So I think it's worth it to invest in these things. So thank you guys very much. If you're interested in these concepts, go ahead and check out the MCRIT website. We've done several podcasts. I've done a number of posts that go through extensively all of the evidence and science behind a lot of this stuff. If you are interested in in all of the references, the 60 or 70 references that I used to make this talk, take a picture of this QR code or head to this website, and you can absolutely get access to the PDF with all of the references. So thank you guys so much for your attention. And at this point, I will gladly invite our moderators back, and I am happy to spend the last few minutes answering whatever questions you may have.
Thank you. That was an excellent presentation. And I think, what I've learned from this webinar, as well as some of the others, is that, although these are geared towards, emergency response crews, I obviously am not a medical professional, but I can apply a lot of these to my own work too. So thank you. So we don't have any questions that have come through the question and answer portal. If you guys want to type a couple questions right now, great. If not, we will provide some of these resources that were given to us prior to the webinar. And, we just want to say thank you so much to Dr. Lauria for this great presentation and all of the resources. I know I could use an opportunity to sit and breathe sometimes, especially during COVID. Oh, here we go. Oh, somebody says, great chat, Mike. Thank you for the work you've done on the topic. That's from James Boomhauer. So thank you, James, for that note.
Thank you.
If there are any other questions, if not, we will say thank you again, and look forward to seeing you all on our next webinar, which is next week. So thank you all again. Dr. Lauria, thank you for all of the great information. Oh, okay, so now we have a bunch of questions coming.
All right, feel free to shoot. I'm happy to answer whatever until we're at time. So
someone says, my greatest takeaway is a way to articulate thoughts and practices that are important to me in a way that can communicate in a format others may be able to understand. Point, I am more concerned with crew feeling like they have the information they need to go on an interfacility call versus getting out the door a minute sooner. What is important, being prepared for the call or getting out the door faster?
So that's a really good question. There's this old adage that slow is smooth and smooth is fast. And I kind of disagree with that a little bit. Slow is just slow. Being smooth is fast. Having all of the information that you need to perform effectively is probably the most important thing. And there's always a balance between those two. So the question is exactly how much information do you need to know before you get out the door? And I think in those circumstances, there's only so much that you need to know. Like you can do plenty of planning on the flight out to whatever scene response, whatever it is, but there are some things that you absolutely need to know. You can't walk out the door without critical pieces of equipment that aren't standard loadout on your aircraft. So there, it's important to know certain specifics, like can this patient actually fit in the aircraft, right? If they're 200 kilograms and shaped like a summer squash and physically cannot fit into the aircraft, that's like a go, no go kind of criteria, and you have to come up with another plan to deal with that. So it's hard to say exactly how much, but the way I think about it is giving the crew enough information to prepare, in other words, to understand, A, is this person very, very sick, critically ill? We need to move a little bit faster and be ready to perform critical interventions. Number two, are there certain logistical requirements or logistical needs that we have to have before we get out the door in order to successfully complete this mission? a lot of the stuff, a lot of the rest of the stuff is essentially, as far as I'm concerned, icing on the cake and can be given later on or en route to a particular interhospital transfer or scene flight. Does that make sense? I hope that answers the question.
Thank you. How is your flight program working around COVID in terms of getting into clinical rotations?
So that's a fantastic question. And the answer is we're still working on that. I don't have a good solution to that quite yet because even for our emergency medicine residents and other residents, we are just now starting to get them back into the clinical environment and rotate and doing things like anesthesia, pediatric anesthesia and whatnot. So we ourselves are still trying to work out a plan with the different services and clinical rotations inside the hospital for making that happen. I think we're on the cusp of that. I think we are doing things like mitigating, for example, in our ICUs, we have a separate area of the ICUs where all the COVID patients are. So trying to get our flight crews into the non-COVID areas of the medical ICU and other ICUs to work on their various skills is kind of where we're headed with that. But we too are still in the process of kind of sussing that out and figuring out exactly what's going to work.
Great. Do you feel that some of these techniques are already incorporated into many of our individual practices and contribute to a lower incidence of PTSD among air medical? And then there's a clarification. I don't know the incidence of PTSD in air medical, but people last for years in this field despite seeing the worst of the worst.
Yeah, so that is a fantastic question. And the answer is, I think they do. I think part of that slow adaptive process is people getting used to seeing really terrible and awful things and also developing their own versions of these skills. So for example, I mean, the way I came on this to begin with was noticing that Bull, that breacher, and that trauma surgeon had developed, without reading any textbooks or any literature or any articles, they had developed these skills on their own. I do believe, although I cannot prove, that there are people in our industry, paramedics, nurses, respiratory therapists, and docs that over time have actually developed and implemented some of these skills because they realize that they work. And although they didn't have the science or understand or appreciate exactly the mechanism that was driving it or how it was working, they noticed it worked for them. The second part of that question, in terms of PTSD, it's hard to say, but I do believe that if you're mitigating the instances where you feel like you have no control, you feel no internal locus of control, like things are absolutely going terribly wrong, you have no control and are unable to intervene or unable to help save this person, that is probably one of the biggest drivers of the post-traumatic stress compendium of symptoms and other things. And I think my hypothesis is, but I cannot prove, that I think long-term, the more we develop some of these psychological skills acutely and begin practicing them longitudinally and giving people, or at least subjectively allowing them to feel less stress, feel more in control, and give them the skills they need to act definitively to intervene and actually make a difference, I think, and I would propose that will help with that to a certain extent, but I can't prove it. I don't have the evidence at this point to say that definitively.
Great. We have one more question. It's a great talk. Wondering if there's any evidence on the ideal balance of technical skills versus stress inoculation in initial EMS education.
Okay, so that is another fantastic question that we don't really know the answer to, where that balance is. But I think the problem traditionally has been that we go through the different modules and units in terms of EMS training and education, whether you're doing an academic, more bachelor's type paramedic or EMS program, or whether you're doing a non-bachelor's or an EMS program or EMT class or whatever. As we go through the prescribed technical skills stations and days and all this other stuff, there's a big gap between just learning those skill stations and putting a tube in a plastic mannequin and doing a full-blown, very stressful scenario. in my opinion, the balance is, although I don't know exactly what that balance is, I do think we jump that gap way too often. We go from like very basic introduction and skills things to like, oh my God, there's a scenario with like smoke and lights and people screaming and noise. And then we expect to just throw them into it and they're going to suddenly, you know, like learn to deal with the stress. And that is not true. That is not true. They don't do it just right away in that acute setting. And it can be detrimental in terms of busting people's confidence, as I mentioned. Where I think the balance needs to lie more is equal distribution between that initial skills practice and introduction, that center stage where we actually develop those skills in combination with the psychological skills and let them practice more under more challenging circumstances, and then stair-stepping them or graduating them to these full-blown scenarios where there's a lot to think about and they have to perform these stressful skills. Like I mentioned, although I don't know exactly where that balance is, I think right now the balance is this bimodal distribution between basic skills introduction and these crazy scenarios with very little in between. And I think if we make that more of a gradual and incremental increase and teaching these people, teaching our colleagues these psychological skills and talking to them about these things, then I think that will be better.
That sounds like a great research opportunity, maybe for the MedEvac Foundation or for you. Well, thank you again. We have no more questions. We appreciate your time today. We appreciate everybody who joined us and tuned in. And we'll send a follow-up email to everyone. And hopefully you'll join us next week. Have a good afternoon.
Absolutely. I hope to be there.
Yeah, thanks.
Take care. Have a good day, guys. Be safe out there.
Bye.